Good afternoon, everyone. My name is Jackie Lizer, and I'm a manager at CAQH, and I'm so excited to welcome you all to our 2023 CAQH Index webinar. CAQH just published the 11th annual index report, and today you'll hear from our team about all of the key information from that report and about how trends from the pandemic are impacting the future of healthcare administration. If you've joined our webinars in the past, you might notice that we're using a new platform. So starting this year in 2024, we have transitioned to Zoom. So we do have a few new logistics for you to review before we get started. Today's session is being recorded. After the presentation, all attendees and anyone who registered will receive an email with a link to this recording after the webinar in the next 1 to 2 business days. Your phones will stay muted during the webinar. However, if you do have a question and you'd like to communicate it with our speakers, you can go ahead and submit your question on the menu at the bottom of your screen. There's a little 2 chat bubbles and it says Q&A. And if you can't see it because you're in full screen mode, if you just hover over the bottom of your screen, your menu should pop up to ask your question. Please feel free to do so throughout the presentation. And then at the end, we'll have some time to review any questions that have popped up. Taking a look at the next slide, I'm just going to run through our agenda before passing it over. First, you'll hear a bit about the CAQH index, just a little bit of background and overview on what the index report is. Then the team will dive into key findings from the report, followed by specific findings for each transaction that the index studied. And we'll wrap things up with a brief industry call to action and Q&A. With that, I'm going to go ahead and pass things over to Erin Weber.
Great. Thank you, Jackie. And thank you, everyone, for joining us today. I'm Erin Weber. I'm the new Chief Policy and Research Officer at CAQH. So part of my role is to support the development of the CAQH Index Report. This year's report is our 11th annual report. Last year was number 10, and we did a big celebration, and now we're moving on. For those of you who are less familiar with the CAQH index, the purpose of the report is really to benchmark industry progress towards automation. We're looking at how many typical revenue cycle transactions are conducted. Things like claims, eligibility, prior authorization. What's the processing cost and time to conduct those transactions? And looking at different modes for conducting those transactions, from manual, picking up the phone, making a call, partially electronic, where we're talking about things like provider portals or IVR, or fully electronic. And in most cases for the transactions that are covered in the CAQH index, that means the HIPAA standards. The report findings are used across the industry for a variety of reasons. We see the index regularly cited in news articles, regulation, strategic planning efforts, and research. Before we get into the details, I really want to thank our CAQH Index Advisory Council members. The council is composed of representatives from health plans, providers, government, standards development organizations, vendors, and other partners who really guide the work that we do. One of the key things that they do is help us understand the trends we are seeing. Does it reflect what's happening in their own businesses and what might be some of the causes? So a lot of the findings you'll see today were really informed and guided by the council. I also want to congratulate Christine Bernaska, our Director of Research and Measurement at CAQH, and her team for all of their hard work to get the report out this year. On today's call, we want to hear from you. So please share your questions and comments in the Q&A function, and we'll leave some time at the end of the webinar to discuss. On the next slide, I just want to highlight that the CAQH index tracks transitions across the healthcare revenue cycle. So from the time a patient encounter is scheduled and the eligibility verification with the insurer has to occur, all the way to the point at which a provider is paid by the health plan. So we're looking at each step in that process and how automated that back and forth communication is between providers and health plans. In addition to our standard revenue cycle transactions. On the next slide, I want to highlight some additional metrics and supplemental questions that were added to the index. Each year, we think about trends we're seeing in terms of automation and use the index as an opportunity to gather additional data from the plans and providers that are sharing information with us to understand more emerging trends. And so this year we looked at additional metrics related to the use of FHIR APIs for patient access and provider directory, pharmacy transactions. We included supplemental questions around artificial intelligence, value-based payment contracts, and particularly looking at provider attribution, information exchange, and the growth in value-based contracts. Finally, this was the first year we were able to segment the data included in the index by provider type. So we looked at the data by generalist, specialist, and behavioralists and saw some really interesting differences. Now, I'm teeing this up, and we're not going to share any of this detail with you today, so a little bit of a bummer there, but what we will do is put out follow-up publications relating to each of these topics over the course of the year. The first one probably looking at this provider type segmentation. And I can tell you there are some really interesting differences across the transactions. Some are fairly stable between provider type, where others like prior auth and eligibility and benefits, we're seeing quite a big difference in cost and time related to those transactions across the different provider types. Before we dig into the report, I just want to cover a couple of definitions and details. I already talked about the definitions we use in terms of electronic and manual, but I want to highlight too, the scope of this research is really related to costs that are scope of the costs are really only the labor time to conduct the transactions. So we don't necessarily include the pre and post work related to these transactions. So you can imagine some of these transactions have quite a bit of that, like a prior authorization. So there may be more cost depending on how you define that. On the next slide, just some of the metrics we are looking at from a financial perspective. The first is cost savings opportunity, and the team's going to cover this as they go through the results, but we're really looking at the savings when a transaction moves from manual or partially electronic to fully electronic. The estimated spend is how much it costs to exchange a transaction by a given modality. The electronic spend is the cost that's necessary to conduct the transaction. You know, transactions are unavoidable, so electronic would be the most efficient. And finally, costs avoided. The amount of money that was saved by doing fully electronic transactions as opposed to a manual or partially electronic transaction. On the next slide is the full list of transactions that are included in this year's index report. I'll highlight that all of these transactions are mandated under HIPAA, with the exception of attachments and acknowledgements. Of course, with the release of the recent interoperability and prior authorization final rule from CMS, the Index Council will be exploring how best to track prior authorization transactions moving forward as part of its work over the next year. And finally, this is no small effort. The amount of data that is included in the CAQH index is really impressive. And again, kudos to Christine and her team for doing this work. The data represents health plans covering about 209 million medical lives, or 60% of total enrollment, as well as 127 million dental, or 45% of total dental enrollment. You know, that's quite a bit of data. And so these medical plans account for 3 billion claims received and about 15 billion transactions annually. Dental is a slightly smaller portion of the volume, with about 198 million claims and 852 million transactions. A really exciting point, and this is why we were able to do the provider segmentation this year, is that our medical provider sample increased by over 100% for this year's report. So this is all to say, this is a really comprehensive assessment of the industry. The more data that's submitted, the more robust and accurate the findings. I remember when CAQH first launched the index and we were only looking at 5 or 6 transactions and the volumes were much lower. It's been really exciting to see this project grow and expand over the last 10 years. Also, if your organization is a health plan or a provider, I strongly encourage you to follow up with our team to get engaged. Participating organizations also receive a benchmark report. So with that, I'm going to turn it over to the team to walk through the detailed findings. I encourage you, as you listen to the findings, to think about the so what of the data. Some transactions only saw minor changes over the past year, while others have more significant adjustments, such as higher costs. Again, we welcome you to share your thoughts in the Q&A about what might be driving these numbers as our team shares what we found. So with that, I'll turn it over to Christine.
Great. Thanks, Erin, and to everyone for joining the call today. As Erin said, my name is Christine Bernaska. I am the Director of Research and Measurement here at CAQH. For the next 15 minutes or so, I'm going to share the 2023 key findings with you. We will start with some context to frame the findings for you and for you to consider as we talk more about the findings as well as transaction details on the coming slides. So in 2022, after COVID-19 stressed healthcare systems, the healthcare industry began to adjust to a new normal, which was characterized by changed social behaviors, policies, and workflows. Utilization began to stabilize as pent-up demand to schedule appointments and procedures lessened after a large increase in utilization the previous year. Hybrid work models became the norm, fostering the continued use and growth of automated workflows. Threats to electronic infrastructures, however, heightened concerns as health plans reported the need for increasing resources to respond to automated entities such as bots and phishing attempts, which ultimately impacted costs and time to conduct these transactions. Staffing shortages continued to impact the time to conduct administrative tasks, especially for providers. With all this said, we saw that electronic adoption improved or remained stable for all medical transactions except two, and improved or remained stable for all dental transactions. Overall transaction volume for both industries increased, although not as drastic as the previous year. Consistent with the last few years, staffing shortages and higher transaction volumes resulted in greater spending on administrative transactions for both industries. For the medical industry, provider time to conduct transactions increased on average 14%, which accounted for 77% of the increase in total medical spend. For the dental industry, provider time to conduct transactions increased on average 22%, which accounted for 95% of the increase in total dental spend. Conversely, the cost savings opportunity decreased for both industries as the gap between provider manual and electronic costs decreased and electronic adoption increased. Next slide. We're now going to look at the data associated with the key findings. The next few slides present highlights related to electronic adoption levels, transaction volumes, spend, and cost savings opportunities. As we walk through these findings, keep in mind the contextual factors I just mentioned. We'll start by looking at medical plan adoption. On this slide, you'll see that electronic adoption improved or remained stable for all medical transactions except claim payment and coordination of benefits, which decreased slightly. For the second year in a row, adoption increased the most for remittance advice at 5 percentage points, followed by eligibility and benefit verification, which increased 4 percentage points. Next slide. Switching to the dental industry, we see that adoption increased or stayed stable for all transactions. Adoption increased the most for eligibility and benefit verification and claim payment, both at 4 percentage points. Next slide. This slide shows that overall transaction volume increased for the medical and dental industries. The number of medical transactions conducted increased 11% to 55 billion, while the number of dental transactions conducted increased 9% to 4 billion. For both the medical and dental industries, electronic volume accounts for the highest percentage of the total volume at 85% and 56%, respectively. Next slide. On this slide, we see that spending related to the administrative transactions increased for the medical and dental industries. Spending on medical administrative transactions increased 50% to 83 billion, and dental spending increased 18% to 6.3 billion. The large increase in spending is due to providers spending more time conducting administrative tasks due to staffing shortages and higher transaction volumes. As a reminder, for the medical industry, provider time to conduct transactions increased on average 14%, which accounted for more than 77% of the increase in total overall spend. For the dental industry, provider time to conduct the transactions increased on average 22%, which accounted for 95% of the increase in the total dental spend. New staff were often inexperienced and required more time to complete tasks, resulting in overall greater spend associated with the administrative workflow. Next slide. We're now going to dig deeper into the medical transactions to see what exactly is driving the spend. Based on reported data, the medical industry spent an estimated $83 billion conducted the transactions listed on this slide. This amount is up 50%, or about $30 billion from the last report. Of the $83 billion, eligibility and benefit verification continues to account for the greatest portion of the total annual medical spend at 51%, followed by claim submission, which accounts for 23% of the total annual medical spend. The increase in spending for eligibility and benefits can be attributed to an increase in provider time to conduct eligibility and benefit verification checks. It is worth noting that the largest increase in spend from last year is for claim status inquiry, which increased 71%. The growth in spend was driven by increased volume and workforce issues, resulting in higher provider time and costs to conduct inquiries. Focusing on costs avoided, we see that the medical industry avoided spending $188 billion through automation, which is up from $182 billion last year. Next slide. Looking at the dental industry, we see that the dental industry spending increased from $5.4 billion to $6.3 billion in 2022. Of the $6.3 billion spent conducting the listed transactions, similar to the medical industry, eligibility and benefit verification continues to account for the largest portion of the total annual dental spend at 29%, followed by claims submission and remittance advice, both which account for 21% of the total annual spend. The largest increase in spend from last year was for eligibility and benefit verification, which increased 45%. This increase was driven by higher provider costs. Dental providers were spending more time submitting accurate claim information given the lack of dental information included on the 270, 271. Inaccurate or incomplete claim information often results in denied submissions or late payment. Thus, time was spent upfront to ensure the data was accurate. Focusing on costs avoided, we see that the dental industry avoided $5.4 billion through the use of automated processes, which is up from $4.8 billion. Next slide. On this slide, we see that the cost savings opportunity for both medical and dental industries decreased as the gap between provider manual and electronic costs decreased and electronic adoption increased. Providers spent more time conducting electronic and manual transactions. The cost savings opportunity for the medical industry decreased 26% to $16.4 billion. For the dental industry, cost savings opportunity dropped 26% to $1.9 billion. As staffing shortages are expected to persist, increases in time to conduct transactions will continue to have an impact across all modes. This should be monitored and considered as the industry works together to identify ways to help reduce provider administrative burden. Next slide. We're now going to look more closely at what is driving the cost savings opportunity for the medical industry. There's a lot of data in this table, so I'm going to highlight some key findings for you. Looking at the average cost to conduct each transaction, similar to last year's report, we see that the biggest cost savings opportunity is for claim status inquiry, followed by eligibility and benefit verification. On average, the medical industry could save $11.63 per claim status inquiry by conducting an electronic inquiry as opposed to a manual inquiry using phone, fax, or email. Similarly, the industry could save over $10 per eligibility and benefit verification by conducting a verification electronically as opposed to manually. Looking across the transactions reported, we found that on average, each manual transaction costs the industry $5.43 more to conduct than an electronic transaction. These savings add up, and for a single patient encounter, the medical industry could save over $43 if all of the listed transactions were automated. The cost savings opportunity for this is larger for providers at $26, while plans could save about $17 per patient encounter. There are also cost savings opportunities associated with moving from portal use to fully electronic transactions. On average, the industry could save almost $3 by conducting a claim status inquiry using the HIPAA standard as opposed to using a portal. Similarly, the industry could save slightly over $3 by conducting a fully electronic prior authorization as opposed to one using a portal. Next slide. We're now going to look more closely at what is driving the cost savings for the dental industry. you'll see that this table mimics the table we saw on the previous slide for the medical industry with just fewer transactions. Looking at the average cost to conduct the transactions listed, similar to the medical industry, we see that the biggest cost savings opportunity is for claim status inquiry, followed by eligibility and benefit verification. On average, the dental industry could save $12.07 by conducting an electronic inquiry as opposed to a manual inquiry. Similarly, the industry could save almost $9 per eligibility and benefit verification by conducting a verification electronically as opposed to manually. Looking across the transactions reported, we found that on average, each manual transaction costs the dental industry $4.29 more than each electronic transaction. And again, these savings add up. And for a single patient encounter, the dental industry could save almost $26 if all of the listed transactions were conducted electronically. Similar to the medical industry, the cost savings opportunity is larger for dental providers at $18.16, while dental plans could save $7.58. Looking at the cost savings associated with moving from portal use to fully electronic transactions, we see that on average, the industry could save almost $2 per transaction by conducting a claim status inquiry using the HIPAA standard as opposed to using a portal. Similarly, the industry could save almost $1.50 by conducting an eligibility and benefit check using the standard as opposed to one using a portal. Next slide. In addition to estimating cost savings opportunities, which we just talked about, we are also able to estimate time savings by moving from manual to fully electronic transactions. For patients requiring all 7 reported medical transactions, a provider could save on average 1 hour by conducting all the transactions electronically instead of manually. For patients requiring all 5 reported dental transactions, a provider could save on average 29 minutes by conducting the transactions electronically instead of manually. For both industries, the largest time savings opportunity is for claim status inquiry. Medical providers could save 17 minutes per inquiry by conducting the transaction electronically using the HIPAA standard as opposed to manually using fax, phone, or email. Dental providers could save 13 minutes per inquiry. The second largest time savings opportunity for both industries is eligibility and benefit verification. Well, that concludes my presentation of the key findings. I know I shared a lot of information over the last 15 minutes or so. If you have any questions, please feel free to ask them in the question and answer panel, or feel free to email us at insights@caqh.org. And before I turn the presentation over to Drew, I also want to thank all plans and providers who submitted data to the report to help us make the findings robust, as well as a special thanks to our Index Council and our partner at NORC at the University of Chicago. With that said, I will turn the presentation over to Drew, our senior analyst on the index. He's going to dig deeper into the individual transactions along the administrative workflow. Drew?
Thanks, Christine, and to everyone for joining us today. As Christine mentioned, I'm going to present findings for the administrative transactions studied in this year's index. For each transaction, I'll share trends in adoption and volume, and where possible, provide some context around those findings. We'll start at the beginning of the administrative workflow with the eligibility and benefit verification transaction. Next slide. Looking at adoption, we see that electronic adoption increased for both the medical and dental industries. For the medical industry, electronic adoption reached 94%. The increase for this transaction was one of the largest among transactions. For the dental industry, adoption increased 4 percentage points as the use of electronic eligibility and benefit verification continued to be promoted within the dental industry. These positive movements towards electronic use is partly due to dental plans continuing to encourage the use of electronic transactions, knowing that provider questions related to eligibility and benefits are one of the top reasons for manual inbound phone calls. Next slide. On this slide, you'll see that overall eligibility and benefit verification volume increased for the medical and dental industries. Plans in both industries indicated that the increase in volume is due in part to the presence of automated external entities, such as bots that repeatedly ping servers. It's important to note that as volume increased, so did spend. Medical spending on eligibility and benefit verifications increased 60% to $43 billion and remains the highest spend among the transactions, accounting for half of the total annual medical spend. Additionally, spending on eligibility and benefit verifications is the highest for the dental industry, accounting for 29% of the total annual dental spend at $1.8 billion. Through adoption of the 270-271 standard, the medical and dental industries have avoided considerable annual costs, $146 billion and $3.5 billion, respectively. Next slide. Moving on to prior authorization. We see that electronic adoption continues to increase for the medical industry. Although electronic adoption remains one of the lowest among the transactions studied after attachments, adoption has increased by 3 percentage points this year. Next slide. Overall volume continued to increase by 23% after dropping during the height of the COVID-19 pandemic. The increase in volume was driven by an increase in all modes, with use of the electronic prior authorizations increasing the most at 61%. Despite increased adoption, conducting prior authorizations remains one of the most time-consuming administrative tasks. As alleviating provider burden remains top of mind for stakeholders, reducing the time to complete prior authorizations continues to be a focus for the industry. Next slide. Focusing on claim submission, medical and dental adoption increased slightly. For both industries, electronic adoption of claim submissions remains one of the highest compared to other transactions. Next slide. After increasing approximately 20% the previous year due to an increase in pent-up demand for services, the number of medical and dental claims submitted rose less than 10% this year, by 8% and 3% respectively. For both industries, there is an increase in electronic and manual submissions. One national health plan indicated that they have been promoting the use of electronic submissions. It's important to note that spending associated with claim submissions also increased, and after eligibility and benefit verifications, accounts for the second highest portion of total annual spend for both industries. Spending on claim submissions rose 67% to $19 billion for medical and 34% to $1.3 billion for dental. The increase in spend is due to providers spending more time submitting claims. Given the lack of dental information included on the 270, 271s, we have been told that dental providers are spending more time submitting accurate information to avoid denials and late payments. Next slide. Attachments is the lowest adopted transaction for the medical industry and the third lowest adoption transaction for the dental industry. Electronic adoption remains low for both industries as an electronic standard has yet to be federally mandated by HHS. Plans, providers, and vendors have delayed efforts to create automated solutions without much federal guidance and industry support, and this has led to incomplete solutions and manual workarounds that continue today. Next slide. The number of attachments submitted decreased for both industries, driven by a drop in manual transactions for medical. The medical industry reported a 22% drop in attachments, while the dental industry reported a 7% drop after increasing the previous year. Volume may be decreasing as fewer supporting documents are needed when submitting payments and prior authorizations in support of administrative simplification. As volume decreased, so did the spend associated with submitting attachments. Next slide. Moving on to acknowledgement, we see that plan adoption is at 100% for both industries. Given that the majority of health plan systems auto-generate a confirmation response after receiving information from a provider or clearinghouse. Next slide. On this slide, you'll see that electronic volume for acknowledgements continues to grow. No manual resources are needed to complete an acknowledgement. Next slide. After increasing last year, we see that medical adoption of coordination of benefits decreased 1 percentage point to 90%. Despite the drop, this transaction is still among the most automated medical transactions studied. For dental, adoption sits at 52%, consistent with last year. Next slide. Looking at volume for the medical industry, the number of coordination of benefits that were conducted dropped 23% after increasing the previous year. As the high rate of job switching in 2021 started to stabilize, changes in coverage were less frequent, thus the need to coordinate benefits decreased. While the drop in volume was highest for electronic COBs, it occurred for all modes. Next slide. On this slide, you'll see that adoption of electronic claim status inquiries continue to increase for both industries. Adoption increased 2 percentage points for the medical industry and 3 percentage points for the dental industry. Next slide. For the medical industry, the number of claim status inquiries conducted increased 19%. A few plans reported that volume increased due to the presence of bots. Conversely, claim status inquiry volume dropped 27% for the dental industry. Dental plans reported faster processing times for claims that led to a decrease in providers inquiring about payments. Now to spending. Medical spending on claim status inquiries grew 71% to $12.5 billion. The highest increase among the transactions, and accounts for 15% of the total annual spend. The growth in spend was driven by increased volume and workforce issues, resulting in higher provider time and cost to conduct inquiries. Medical providers reported spending, on average, 24 minutes conducting a manual claim status inquiry, costing approximately $12 per transaction. The highest time and cost among the transactions along with prior authorization. Spending decreased 15% for the dental industry as providers conducted fewer inquiries due to faster payments by plans. Next slide. Now on to claim payment. For the medical industry, adoption dropped 2 percentage points. Conversely, dental adoption increased 4 percentage points, the highest increase among the dental transactions, along with eligibility and benefit verification. Dental associations continue to promote and encourage the use of EFTs as a more efficient option to obtaining payment. Next slide. Overall, claim payment volume increased 9% for the medical industry, and with an 8% increase in EFT volume. It should be noted that the increase in EFTs aligns with the increase reported by NACHA during the same time frame. The dental industry experienced a 12% increase in volume, driven by a 39% increase in EFTs. As volume increased, so did spend, but at different rates for the industries. Spending increased 2% for the medical industry as higher overall volume was countered by lower manual costs for providers. For the dental industry, however, spending increased 20% due to an increase in volume and provider costs. Next slide. And lastly, we'll talk about remittance advice, the final transaction in the administrative workflow. Adoption increased 5 percentage points for the medical industry to 88%, the highest increase among the transactions. Dental adoption remained stable at 36% after experiencing a substantial increase the previous year. Next slide. Looking at volume, medical volume decreased 22%, while dental volume increased 4%. Use of portals decreased for the medical and dental industry, 36 and 13% respectively, as the practice of duplicating remittance advices on plan portals and through ERAs appears to be declining. Now to spending. Spending decreased 20% for the medical industry, as the cost to conduct a remittance advice manually dropped for providers. Spending remained stable for the dental industry, as a slight increase in volume was driven by an increase in use of the HIPAA standard. And this concludes my discussion of the findings related to the transactions studied in the index. For more information on the individual transactions, I encourage you to look at the 2023 index report posted on the CAQH website. I will now turn the presentation back to Aaron to talk about actions that the industry can consider to help maintain and improve on the achievements just discussed. Aaron?
Thanks, Drew. I appreciate both Christine and Drew walking us through all of that detail. It's always a balance it's always a challenge to balance the content of the presentation with the really interesting nuances we're seeing for each of the transactions. But let's take a minute to pull up before we move on to questions. I want to share some of the imperatives that the Index Council and our team identified as we really dug into the data. But I also invite you to share your own thoughts and comments in the Q&A panel and appreciate those that already have done so. But what does all of this, what's kind of the so what of this data? What does this mean for our industry? I think the first key takeaway is that we really aren't even close to realizing the full benefits of automation. A lot of the low-hanging fruit has been captured, but significant savings opportunities exist. And in some instances, we're seeing our spending increase. There are still savings opportunities with high volume transactions, including eligibility verification and claim submission. How can we capture that? Many of you may know I wear a couple hats at CAQH, so I want to highlight a couple initiatives on the horizon that may help close that gap. Earlier last year, the National Committee on Vital and Health Statistics recommended a set of core operating rules related to eligibility and benefits transactions that will help close that remaining automation gap for eligibility and benefits. And as you saw, that 10%, not even adoption gap accounts for several $billions of cost to the system. The operating rules will address issues like telemedicine coverage. Is a prior authorization required? Detail about remaining coverage benefits, tiered benefits, some procedure level detail, and attribution status under a value-based contract. Right now, these are all topics where providers are having to pick up the phone and make a phone call or go into a portal to get a clear answer on a patient's coverage. So we anticipate that as these operating rules are adopted, that automation gap will start to close. Additionally, CORE worked on new rules related to claim submission this year. And I saw one comment in the chat related to denial rates. And one of the things I think is interesting about this is even though claims are almost fully automated, the industry denial rate is still around 10%. So how can we improve the data that's submitted and the quality of those electronic transactions so that we can reduce those denial rates over time? I'd also be remiss not to mention CMS's latest final rule related to interoperability and prior authorization. In that rule, there were requirements around response time to a prior authorization request, really reducing the amount of time and back and forth, and other requirements that will probably increase adoption of electronic prior authorization because providers will be able to get more detail in a reliable way using the prior transaction. Second point is really to help address some of these rising costs, especially given much of the savings opportunities are attributed to providers. Investments in workforce training will pay off in the longer term. Research shows that organizations that invest in their workforce also retain their employees longer. So better trained, longer tenured staff can really help reduce these transaction costs and staff time over the next couple of years. So really encouraging, particularly provider organizations, to think about how can they educate new staff and onboard new staff to become more efficient in their use of these automated transactions. And then finally, with automation, new challenges do emerge. Every day we hear about biases in AI, the risks associated with applying automation to claim reviews like systematic denials, and the high costs of cybersecurity. As our industry moves into the early adoption phase of these emerging technologies, a full assessment of the risks and benefits must be undertaken to ensure long-term success. So with that, I want to encourage you to engage with CAQH on these findings. Do they align with your own experience? We're really interested in hearing from you what this looks like at your organization. So now we're going to turn to our Q&A portion. I really appreciate the questions and comments that have been submitted so far. I know Jackie mentioned there is a Q&A button at the bottom of the screen that you can use to submit questions. First question, though, I'm going to send over to Christine, which is how can organizations get involved in participating in the CAQH index?
Yeah, great. Thanks, Erin. Great question, and I'm glad someone asked that. We are always looking for new plans and providers, as well as vendors, if they're interested, to participate in the index. If you are interested, you can email insights@caqh.org, and I will or Drew will reach out to you and provide you with some information, not only about the index, but the upcoming data collection schedule. You can also visit the CAQH website and go to the Insights tab, which contains information about this year's index as well as past index. And there is a Become a Participant button on that page, which you can then submit your name and someone will get back to you that way as well.
Great, thanks, Christine. Another question we've gotten in a couple different formats is how is the data for the index collected, both on the provider and the health plan side? And how do we ensure we have robust samples of that data?
Yes, so as you mentioned, Erin, early on the on the plan side, we are fortunate enough to work with many national plans, both on the medical and dental side. And as you mentioned, on the medical side, the plans that we have represent 60% of covered lives, and the dental plans that we have participating represent about 50% of covered lives. And in terms of how do we collect that data, the data collection is survey-based. And so beginning of data collection, each plan or provider will receive a survey in which they submit data related to the transactions. We ask about volume, time, cost, all best estimates. So on the plan side, we have a list of plans that we have worked with. Many of them we've worked with for years, and so we continue to reach out to them, and they continue to submit data. We also, through word of mouth and through our contacts, continue to enhance and increase the number of plans, medical and dental. On the provider side, you mentioned that we increased the sample this year. We work with NORC at the University of Chicago to collect that data, and we use a random sample of providers from lists that they have, as well as tap into some of the provider data that we have in-house to randomly select providers, MDs and DOs with various specialties, to reach out to them via email and using a similar survey link and tool that we send to the plans.
Great. Another interesting question, and I think it's a good one, is as you look through this, what are the key factors preventing providers from adopting electronic transactions? You know, if you look at the data, it saves time and costs. It almost seems like a no-brainer, but yet each year we're just making incremental progress. What are some of the reasons, and I have my own thoughts, so I'm happy to chime in, but what are some of the reasons you're hearing and seeing for this as well?
Yeah, it's a good question. I'm, interested to hear your thoughts. My first thought would be, I know there's costs from a technology standpoint. So from working with some of the providers and talking to some of them during follow-up when we ask them those questions, some of them really will state that there's a cost to implementing technology. So I guess if I were to say what is the main reason, I would definitely say that that's probably up their cost, and staff to be able to train up and do that type of work.
Yeah, I think the other thing that we've heard in some of the work we do on the core side of CAQH is that the quality of the data for some of these transactions, not all of them, but the quality of the data included in the electronic transaction may not be as robust as what they're receiving in a portal or a manual format. And so there's this desire to kind of default to where you get the most information, even if it takes a little more time and effort, because then you don't have to do that follow-up. So, that's one of the reasons we work on operating rules, is really to enhance the content of those, electronic transactions, because a generic response doesn't necessarily help in particular instances. So.
No, Erin, I think was seen a lot during COVID, particularly with telemedicine and some of the things that came up during COVID, that the electronic transactions, they didn't necessarily take into account and didn't meet the needs of the industry. So a lot of work was being done outside of the workflow, and it was manual work that needed to be done.
Yep, totally agree. Another question, I brought this up a little bit earlier when I was speaking, but somebody asked if we've looked at whether electronically processed medical or dental claims lead to lower denial rates. And the point being, if denial rates are lower, that may give more incentive to providers, or more savings to, drive adoption. And, I think one of the things that we're seeing is that we're almost fully electronic with the claims transaction, particularly on the medical side, but yet there are still, a 10% denial rate really across the industry. And I think that's in part due to, some lack of standardization still within the transactions. Do you have any perspective on that?
I don't. I would agree with what you're saying in terms of the lack of standardization. I will say that for the index, the council brought up, which was, and we've tried to collect information on denial rates. We have not been able to collect a robust enough sample to be able to report on that, but that is something that I know the council is interested in diving deeper into, and we're interested in gathering additional data. So I'm hopeful perhaps this year, or if not in the coming years, we'll be able to provide some more information on denial rates and perhaps link it to some of the work I know that core and the team has been doing around that.
Great, thanks, Christine. A couple comments also around, I mentioned that CMS has finalized their interoperability and prior authorization rule, and that the council will really be thinking about how to adjust the index and our data collection to account for that. Some components of the rule include requiring health plans to give patients and providers a reason for denying a prior authorization request, as well as how to resubmit the request or appeal the decision, and also to send decisions for urgent requests within 3 days and 7 days for standard requests. And a lot of these requirements start in the 2026-2027 timeframe. The other interesting thing about this rule is that it is requiring the support for Medicare Advantage and Medicaid and federally facilitated marketplace plans to support FHIR to exchange prior authorization. And the National Standards Group at CMS has announced that they will do enforcement discretion on the use of the HIPAA mandated prior authorization transaction, which is the X12-278. So I think that's something both from a insights perspective and a core perspective that we're really going to be looking at over the next year or two to see how that impacts usage of the transactions and help the industry measure, the cost to implement, and then the value that they're seeing as it becomes more commonly used across the industry. So certainly on our roadmap for the next year. Let's see, any other questions? One question is whether CAQH or CORE will be looking into improving the 277 transaction, which is the 277 CA, and that is a transaction that we have been doing some work on this year to help create more standardization in the data that is included in that transaction. The core participants are actually voting right now on some requirements there. So stay tuned for more information from that perspective. The other transaction is the claim status transaction, and I think you saw a lot of opportunity there. We are doing some environmental scanning on opportunities to include more robust data in that transaction as well to help drive adoption and usage, and expect to start rule development for operating rules this year on that transaction as well. So with that, we are about at time, and I'm not seeing any other questions coming in. So I will just say thank you very much to everyone for attending today. Really encourage you to take a look at the report, dig into the details. If you're interested in learning more or have insights that you think we might have missed, please reach out to us. We're always happy to have a conversation, and really, the more we can share and educate the industry about the opportunities related to automation, the better. So thank you so much for your time today, and we look forward to working with you on the next index.
Thank you.